A missing or out-of-date treatment plan for anxiety is one of the fastest ways to get a claim denied for insufficient medical necessity. This guide covers the ICD-10 codes clinicians use most, how to write measurable treatment goals, and the documentation practices that keep claims clean. A treatment plan for anxiety is the roadmap that guides your team in helping the patient manage their condition. It documents the diagnosis with its ICD-10 code, treatment goals, interventions, a review timeline, and how progress will be measured. Many payers, Medicaid programs, and accrediting bodies treat a completed, individualized treatment plan as a hard compliance requirement. Goals should be specific, measurable, achievable, relevant, and time-bound, so both team and patient can track progress. Across anxiety claims, denials trace back to one recurring gap: the medical necessity criteria were never documented. Claims coded F41.1 for GAD were denied because notes never documented the 6-month duration criterion. Payers questioned whether GAD was justified. Using F41.9 as a permanent code rather than provisional triggers payer scrutiny and signals lack of individualized planning. In ICD-10 anxiety-related diagnoses live in the F40 to F48 block. Here are the 4 codes your team reaches for most often. Let us walk through all 4. F41.1, Generalized Anxiety Disorder, or GAD. GAD is characterized by persistent, free-floating anxiety not tied to a specific situation, lasting at least 6 months. Your notes must reflect the 6-month duration criterion, plus associated symptoms like restlessness, muscle tension, sweating, or insomnia. Payers may deny F41.1 claims if documentation does not clearly show criteria are met, a common preventable denial. F41.9, Anxiety Disorder, Unspecified. F41.9 is appropriate when anxiety is present, but a specific subtype is not yet confirmed, often used as a provisional diagnosis. Note why unspecified. For example, symptoms present only 2 months, so the 6-month GAD criterion is not yet met. Plan to refine to F41.1, F41.0, or another specific diagnosis, as soon as the evidence supports it. F41.0, Panic Disorder. F41.0 is for recurrent, unexpected panic attacks, accompanied by ongoing fear of having more. Do not use F41.0 if panic attacks are better explained by a specific phobia or another primary diagnosis. If agoraphobia is also present, F40.101, agoraphobia with panic disorder, is the more precise code. F40.10, Social Anxiety Disorder, also called social phobia. Social anxiety disorder is coded F40.10 in ICD-10 and covers fear of social or performance situations where scrutiny may occur. Notes should capture which social situations are feared, the degree of avoidance, and how it impairs daily functioning. With the right diagnosis code in place, the next step is goals and objectives. 3 areas appear in virtually every anxiety treatment plan. Let us walk through all 3. Goal Area 1. Reduce the frequency and intensity of anxiety symptoms. Example short-term objective. Client will reduce daily anxiety ratings from 8 out of 10 to 5 out of 10 within 4 weeks through daily relaxation and cognitive techniques. Tie objectives to a standardized tool, the GAD-7 or Beck Anxiety Inventory, so progress is quantifiable. A long-term goal, maintaining minimal anxiety, GAD-7 scores in the 0 to 5 range for 3 consecutive months. Goal Area 2. Increase the patient's ability to manage anxiety through skill development. Evidence-based interventions include CBT, progressive muscle relaxation, mindfulness, and guided imagery. Example: client will learn and implement 3 new coping strategies over the next 6 sessions and report effectiveness of each. Measure progress through homework completion and the patient's reported sense of control when anxiety occurs. Goal Area 3. Decrease avoidance and restore normal daily functioning. Example using gradual exposure. Client will confront 1 feared situation per week, staying at least 30 minutes over 8 weeks. Concrete functional objectives, like resuming an avoided activity within a set time frame, are observable and patient meaningful. Measure progress through patient journaling about exposures and direct clinician observation during sessions. 2 compliance requirements clinicians most often miss. Most payers expect treatment plan reviews at least every 90 days for outpatient care. Document the review even when nothing changes. Both clinician and patient should sign the initial plan and every update. Missing signatures are a common citation in accreditation audits. Behave EHR is designed to support every step of the anxiety treatment planning process, from guided templates to review reminders. Treatment plan templates prompt clinicians for diagnosis, ICD-10 code, goals, objectives, interventions, and signatures. Missing fields block finalization. Automated reminders flag approaching review deadlines so teams do not miss required update dates. As ICD-11 adoption approaches, the platform is designed to support dual coding alongside current ICD-10 billing workflows. Stop letting documentation gaps drive denials. See Behave EHR's treatment planning module. Guided templates, review reminders, ICD-10 coding. Book a 20-minute demo at behavehealth.com.